Welcome to the WPS Data Detective Depression Screening Denials webinar. My name is Mary Mucko. I am a member of the WPS Provider Outreach and Education team, and I will be your presenter today. Joining me is my friend and coworker, Ashley Dakota. Ashley will be helping me today by monitoring the chat feature for new presentation-related questions and by placing some helpful items into the chat for your reference. Here is our objective and agenda for today. The objective, of course, is to provide you with an understanding of how to avoid depression screening claim denials. The agenda items listed on this slide should look very familiar. These are these exact same items that are shown in the description of this video, the one that you saw when you registered for today's webinar. My plan is to reveal the most common reasons that WPS denies claims for G0444. That's the HCPCS code for depression screening. I'm going to discuss ways to avoid those denials and share resources to help you bill and receive proper payment. You will find our legal disclaimer at the end of this presentation. The purpose is to remind learners that although we made every effort to provide up-to-date information in this education, the information is subject to change. It is on the CMS website where you can find access to regulations and rulings that will always prevail. We do encourage you to share our education with anyone you deem appropriate. The disclaimer and the presentation materials will serve to make everyone aware of the disclaimer content, and we do ask that you please do take a couple of moments to review it. Some time ago, back in December 2011, CMS published a National Coverage Determination, or NCD, to outline their intent to allow Medicare payment for depression screening. NCD 210.9, titled Screening for Depression in Adults, includes all of the items listed here on this slide. Now, in addition to embedding a link to the NCD, I've embedded a link on this slide and in your presentation materials to CMS's original consideration for screening for depression in adults. Now, just a few years back, in response to a CMS Innovation Challenge, WPS submitted a proposal and was awarded a grant from CMS to provide education about depression screening. The goals were outlined in that proposal to CMS before they awarded us with that grant, and they were goals to increase the use of this benefit and to decrease the number of claims for attempted suicides reported on WPS claims. Now, we not only met, but we exceeded these lofty goals based on the flood of education we provided and the willingness of providers in our MAC jurisdictions to begin billing for this screening service when presented with an opportunity to do so. So we are so very grateful for the efforts of our provider community, and we want to continue to make prompt and correct payment to those eligible providers that render this valuable service to eligible beneficiaries. And that's another reason why I wanted to present this information today. So that brings me to the first item on today's agenda. What are the most common reasons why WPS denies claims for G0444 depression screening? To determine the reasons for depression screening claim denials, I used a claims denials dashboard. It was created by our Insight team, and that is the name of the staff in one of our internal departments here at WPS. Those are our data analysts, and they created this tool so that those of us in Provider Outreach and Education, or PO, we sometimes call it, can analyze the actual claim submission data to determine education needs and to provide education to lower the number of rejections and denials. The reason we do so is based on CMS directives, and it is in Chapter 6 of their Medicare Contractor, Beneficiary, and Provider Communications Manual. And I've asked Ashley to place a link to this publication in the chat for those that may be interested in taking a look at it later. Now, each month, our data team staff adds 1 month of data, and they take away 1 month of data. So we can view this data in this claims denials dashboard in 3-month time spans. The dashboard allows a user to filter the data to view specific data. So for instance, we can take a look at one of our jurisdictions or both of our jurisdictions. We can choose to view Part A claim data or Part B claim data or even both, and so on and so forth. So to pull the data that I used for this webinar today, I choose to view only Part B denied claims for HCPCS code G0444. I did not choose to filter by provider, specialty, by state, or by county, although I could do so if I'd want to. Because I wanted to track the trending of denials for this code, I pulled three different date spans. I pulled data for claim submission dates August through October of 2025. I pulled another time for September through November of 2025 data. And finally, I pulled data for October through December of 2025. Then I analyzed the data in all three of those sets of data. The data I analyzed revealed the same top 4 denials across all submission date periods. Those claim denial reasons are listed here on this slide in descending order. So the number one reason for denial based on the claim submission data, actual claim submission data to WPS, is that payment is included in another service on the same day. In other words, payment is bundled and separate payment for G0444 was not allowed. Wasn't allowed for that depression screening. The number two reason for denials in our Part B claim jurisdictions, both J5 and J8, is that the number of days or units exceeds our acceptable maximum. And remember, there is a national coverage determination that provides the frequency parameters for this service. Now this is followed by the number three reason, which is very similar. Denied services or units of service are exceeded. And rounding out the top 4 reasons for denials across all time frames that I analyzed for today's webinar is denial for collection of fee-for-service during periods of managed care. Now I'm going to take these apart one by one in just a little bit to tell you how you can avoid these errors in the future, but I do have a few other top denials that I want to throw in. Now these are not consistent in the order of denials, but they did show up often in the data that I analyzed. First of all, Medicare does not pay for this many services in this time period. Once again, that should signify to you frequency parameter. Another top denial is duplicate charge paid on such and such a day on claim ICN, and ICN stands for internal control number. That's the control number for the claim. So really what that means is that a duplicate charge was already made on a certain day on another claim, and here's that ICN for you. These are those reasons, of course, that print out on your remittance advice. Another reason why we're denying G0444 across all of the time frames that I analyze data for is that Medicare only covers this service in certain settings. We'll talk about those in just a bit. And finally, the other top denial that I want to talk about today that was consistent across all three of those time periods that I looked at was that the claim must be submitted or must be sent to the EGHP first. And that EGHP, if you look in the notes for the slide, stands for Employer Group Health Plan. So that means Medicare is the secondary payer. So next, I want to talk about ways to avoid denials for G0444. I've already revealed the most common reasons. That was first on our agenda today. And second on our agenda was that I was going to share information to avoid these in the future. So that number one reason for denials was payment included in another service received on the same day. Medicare denies depression screening when it is rendered with certain other services that are billed on the same day. Providers can use the National Correct Coding Initiative, NCCI Procedure to Procedure, or PTP edits, to learn which services that payment for depression screening is bundled into. Now, when reviewing those edits, if G0444 is listed as the column 2 code on the procedure to procedure edits, those are files out on CMS's website. I'm going to give you those resources later. When that occurs, payment for G0444 is bundled into payment for that column 1 code. You'll need to look at the modifier indicator column on the edit in order to determine if payment can be allowed when you report an NCCI related modifier. Now, if you choose to report a modifier, you need to remember that the documentation in the patient's record will need to justify using that. Payment for G0444 is always bundled into payment for an initial preventive physical exam or an IPPE. It also always bundles into the initial annual wellness visit or the AWV. Now, this is not the case when G0444 is billed with the subsequent annual wellness visit, since depression screening is not a required element of that service. Some of you submitted pre-submitted questions during the registration process, and one of them was specific to billing for an E&M service on the same day as G0444. When billed with an E&M service, G0444 will bundle into the E&M service. But when you check the NCCI procedure to procedure edits to determine if an NCCI related modifier can be appended to that E&M code to unbundle payment for G0444, you'll find that CMS allows you to append an NCCI related modifier, which does include modifier 59, but only when documentation justifies reporting the modifier. So you need to make certain that the documentation in your medical record does support using any modifier, any NCCI related modifier, including the 59, to unbundle payment. We do have a fact sheet on the WPS website, and I'm pulling that over now, making it a little bigger so that you can see it better. This is the depression screening fact sheet from our website. You don't need to worry about the link to it or the web address, because I've included that in the resources section of today's presentation. But when looking at this fact sheet, we do address bundling. It's near the bottom of this fact sheet. And I'm scrolling down that fact sheet to show you that we do address those common services performed with G0444 and the bundling status. The IPP, the AWV, always bundles, and look what we tell you here, no modifier overrides it. That means you're never going to receive separate payment for depression screening when you're billing it with the IPPE or the AWV. For the AWV, there is no edit for this code pair. There's no required modifier. Medicare will consider payment for both, but that is the subsequent annual wellness visit, not the initial one. And last but not least are those E&M services. The G0444 does bundle as a component of the E&M. So you need to look to column F of those procedure to procedure edits to see if CMS allows the use of a modifier to indicate that Medicare considers the services as separate. When documentation supports it, you can append an NCCI associated modifier, which does include a 59, to show that the service can be separately billed, and Medicare will then allow payment for it. So I just wanted to show you where you could find that information out on that fact sheet. We'll take more look at that fact sheet in just a bit. But right now we're going to move on to the second most common reason for denials. The number of days or units exceeds our acceptable minimum. Providers are going to see this reason when the benefit maximum for the time period has been reached. We often refer to this as a frequency denial, and a frequency denial is a form of a medically necessary edit, or it goes into that category. So as such, you're going to want to consider presenting your patient with an ABN if you believe that Medicare may deny the service because it exceeds the benefit maximum for the time period. To avoid these denials, you're going to need to make certain you're asking the patient questions to determine if any other entity may have already provided and billed for depression screening. You can also check the next eligible date in HETS or SNAP. And HETS is the HIPAA eligibility transaction system. It's used by electronic billers. And SNAP is the WPS Secure Net Access portal. And these are both tools that you can use to find the next eligible date for depression screening. Now, the portal user manual provides instructions and illustrations on how to use all of the SNAP functionalities. There is an embedded link to this manual in your presentation materials, and I'm going to talk about that resource a little bit more later on in this webinar today. Let's move on to the next most common reason for denials: denied service. Units of service are exceeded. Another type of NCCI edit is one that prevents improper payments based on CMS's medically unlikely edits, or MUEs. And MUE is the maximum units of services that can be reported for a HIPICS or CPT code on the same day by the same provider for the same beneficiary or patient. Now, most MUEs are published on CMS's MUE edit table, but some are considered confidential and are not posted. For G0444, the MUE is one, and that means based on CMS policy listed as the MUE rationale for the out on that MUE table, only one unit of service can be reported by the same provider for the same beneficiary on the same date of service. Now, when more than the MUE value is reported, a denial will occur. And if that happens to your claim, you would need to check your records and the claim to see if the number of units were reported correctly. Another common denial across all time frames that I analyze data for is collection of fee-for-service during periods of managed care. Sometimes those reason codes that print out on the remittance advice are a little cryptic. This one gives you just enough information to make an assumption, as I did, but I actually sent this reason over to our systems folks and said, is this denial really what I think it means? And it was. This denial occurs on a claim submitted to WPS for a beneficiary who has elected a Medicare Advantage, sometimes we call that MA, plan. To avoid these denials, you need to check patient eligibility and submit the claim to the MA plan, not to WPS. Be sure appropriate staff in your office knows to ask to see the patient's Medicare cards. They should also ask if coverage has changed, if another plan, one that is not original Medicare or WPS, has processed their claims. You might also consider asking who their Medicare mail is now coming from. I know that gets a little difficult during those open enrollment periods where you get a lot of mail from a lot of plans asking you to consider signing up for those plans. Remember that patients can enroll or disenroll during that open enrollment period. Their coverage could change from year to year. So it's important that the appropriate staff knows to ask those patients questions. Ask to see those cards. You know, the best practice is to ask every time. Something could change. So you'll need to check eligibility records to see if the patient is a traditional or original Medicare enrollee. In that case, you'd submit claims to WPS. Otherwise, you need to submit claims to the MA plan, not to WPS. And remember, because we don't know what's in that contract or what that MA plan offers, we are unable to answer questions about coverage and payment for those beneficiaries that have chosen an MA plan to process their Medicare Part A and B claims. Another common denial is Medicare does not pay for this many services in this time period, a little bit more like those MUEs that I've already talked about. Medicare pays only once per year for depression screening. And this claim, or the claim edits, I should say, are set up so 11 full months must pass following the month in which the previous screening occurred. An example of this would be depression screening done on January 10 of 2026. That means the next available depression screening would be January 1 of 2027. 11 full months must pass following the month in which the previous screening occurred. We looked at that fact sheet just a little bit ago. This information is also on the fact sheet. This is up at the top. And we talk right here about the fact that there must be 1 year between screenings. And it provides an example for you there. Okay, things to remember. All right. Next up, just to talk a little bit more about finding that next eligible date. Remember something I mentioned a little bit earlier. You can use HETS if you're electronic biller, or SNAP to find that next eligible date or next date eligible. Duplicate charge paid already on another claim. Now, there are multiple reasons for claim denials that occur due to duplicate charges, but this is the specific one that printed out or showed up in the data that I analyzed. Another type of duplicate, but one not found for these claims, would be, for example, duplicate charge on a claim currently in our system. The MCS claims processing system, or the computer claim logic, the processing logic, will know that there's another claim already in the system that it's duping up against. Duplicate claims cost everybody money. Any denied claim costs everybody money. You need to correct it or see what you can do so that you are awarded payment if you're eligible for payment. That costs money, time, efforts within your office or organization. And it also costs WPS money to reprocess claims or do appeals on those claims that were denied. So we like to offer this kind of education to avoid those denials. Similarly, duplicate charges for much of my time in Medicare, and that's been decades, folks, is just always something that continues to be problematic. We have offered education very often, and these continue to be something that, as I like to say, kicks us in the pants. So the data that I analyzed shows duplicate denials have occurred because the service was already paid for on another claim. And when this happened, the reason that prints on the remittance advice is going to show you that paid date and that other claim internal control number, or ICN as we like to call it. To avoid these denials, verify the status of claims before refiling a claim. You can use the interactive voice response system or the IVR system, or you can use SNAP. If you are billing on a 30-day cycle, or if you have a billing service who submit claims every 30 days without verifying that claim status, stop doing so. Repeated submission of duplicate claims is considered an abuse, and abuse has the potential to become fraud if it's not fixed or avoided. We do have a helpful resource on our website that provides tips on how you can avoid duplicate denials as well as many other denials. The name of that resource is Common Claim Denials, and I've asked Ashley to place the link into the chat. If you're looking for that resource and you don't have that link handy, just go out to our website and enter the words Common Claims Denials or Common Claim Denials in the search, and you will see this pop up in the matches that come back. Let's talk about the fact that Medicare only covers this service in certain settings. That's based on information in that national coverage determination that I talked about at the beginning of this presentation. Based on that NCD, Medicare covers depression screening only when furnished in a primary care setting with staff-assisted depression care supports in order to ensure accurate diagnosis, effective treatment, and follow-up. This slide includes valid place of service codes to bill depression screening. CMS does also allow this service to be rendered via telehealth. That is place of service 02 and 10, and I have asked Ashley to add the depression screening place of service codes to the chat when they're rendered or when it's rendered via telehealth. I neglected to place those on this slide, but 02 and 10 are also covered places of service for depression screening. Now, CMS does provide a definition of a primary care setting, and I'll point this out to you when I cover resources later in this webinar. And finally, another top reason for denial, Medicare, or the claim must be sent rather to the EGHP first, that employer group health plan. This means that Medicare eligibility records show that this beneficiary has another insurance that is primary to Medicare. This slide provides the steps you can take to avoid this kind of denial. Make certain that you're collecting accurate MSP data from your patient or their representative. Ask questions. Do you have another insurance? Can I see your cards? Has something changed? Do you get mail from another payer? So on and so forth. Check patient eligibility records to determine if another insurance is primary to Medicare. Be certain that you're reporting any known primary payer on that Medicare claim, and submit a claim to them first. For example, I'm working, my husband's retired, he has Medicare, but I have an employer group health plan. So my insurance is primary over his Medicare coverage. My insurance has to pay first on my husband's claims, and then a claim is submitted to Medicare to see if they can pay as a Medicare secondary payer. Make certain you're entering all the required MSP information on the claim. This could mean entering items such as value codes or condition codes or occurrence codes. To see those claim form instructions, you can refer to CMS's Internet-only manual. Those are available out on the CMS website, not just the payment, the claim processing manual, but other ones as well. I'll show you how you can find those right here. If you're out on the CMS website and you scroll down, over here in the right side of your screen, open up the drop-down menu for manuals, forms, and transmittals and choose Internet-only manuals. You will see a list of entries of the Medicare CMS Internet-only manuals. I talked about this one earlier, Chapter 6 of 100-09. The Medicare Contractor, Beneficiary, and Provider Communications Manual includes those instructions that tell us that we have to use data to determine education needs. I talked about that earlier. The Claims Processing Manual is publication 100-04. You can see all of the chapters are listed. But if you move to Chapter 26, you will see completing and processing of the CMS 1500 data set. There's also Chapter 24, which is completing and processing the 1450 data set. I'm talking about Part B today, so I'm opening up the 1500 data set, and this section of the Internet-only manual goes item by item through that Medicare claim form and tells you what you need to report on a Medicare claim. Okay, so if there is another insurance that's primary to Medicare, you're telling us that here in item number 11. Okay, you're saying yes, there is another insurance primary to Medicare. Well, then there are other items on the claim form that you have to enter. Okay. If there's no other insurance primary to Medicare, you do need to place the word none in item number 11. But if there is other insurance primary to Medicare, you need to say yes in item 11, and then you need to add additional information about that other insurance. So make sure to avoid these types of denials, that you're adding all of that information to the claim. Let's get back to the PowerPoint here. Bear with me just a moment. All right. Ashley, can you let me know if you can see the PowerPoint once again?
I can see your PowerPoint.
All right. Thanks so much. It went away on me for whatever reason, but it's easy to find. I just want to make certain you're able to see it. So those are things you can do to avoid those those types of denials rather. All right, in the announcement or the description for today's webinar, I told you that I was going to reveal the top reasons. I've done that for denial of G0444 depression screening, that I was going to tell you how you can avoid those denials, and I talked about each of those ways or multiple ways you could avoid those denials. Now I'm going to cover resources for G0444, something that you can come back to after this webinar today to find those resources you need in order to bill this service correctly, because we want to make certain that we issue prompt payment to those of you that render this very valuable service for Medicare beneficiaries. It's really a win-win for both patients and providers for Medicare to now be able to pay for depression screening on a yearly basis. So here is existing depression screening education. I've embedded links in your presentation materials. The fact sheet is that information that I've been showing you here and there throughout the presentation today. And I do want to open that because there's a lot of great information there. When you go to the WPS website, of course, you will need to choose your jurisdiction, and I am just selecting one of our two Part B jurisdictions and accepting the CPT licensure agreement. But here is that depression fact sheet. It tells you that depression screening, the coverage criteria that applies is anyone's eligible for it. However, they have to be absent of any depression signs or symptoms. It's a screening. It can't be performed on someone that already has depression. It only applies as a screening, not to someone who has depression or that chronic condition that's caused by depression. I talked about frequency parameters, 1 year between screenings, that's right here. It has to be furnished in a primary care setting, that is right here. And the description for depression screening reads 5 to 15 minutes. And this does include the time spent to administer the screening tool, interpret the results, and use those results as appropriate. And the expectation is that when those results are negative, that there be an entry by that billing provider in the record that refers to the fact that the screening was negative and there's no further treatment planned, something to that order. Not exactly those words, but there does need to be an acknowledgement that the results were negative, and there's no need for any future plan of care relative to depression. So this talks about the documentation you need. You need to document the tool you used, how you administered it, the time in minutes to administer and interpret the results, and of course use of the results by the healthcare professional. If the professional is a physician billing the service and the nurse administers the test, the use of the results by that physician need to be included in the medical record. Is there a plan of care? Is there a plan for follow-up? Is there not? Why not? Because the results were negative. That needs to be in the documentation. This speaks to the tools to be used for administering the depression screening. CMS does not choose a tool for you. They allow you to choose what works best for you in your practice. There's some considerations for choosing a tool we've included here in this fact sheet. This speaks to time. This time spent doing these tasks right here can be counted when choosing, when determining whether you meet that 5 to 15 minute threshold. Here's a bit of information about the plan of care and follow-up. Today we're really talking about reasons for denials, so we're not going to dive into this, but we do have recordings of previous education that really delve more into that plan of care and follow-up. You can find those on our YouTube channel. And a little bit more about billing. You know, what place of service can you choose to bill? And remember, we do allow places of service 0, 2, and 10, which are telehealth. They should be added to this on our website, and I'm going to be working on that following this program. Here's some information about bundling. We already showed this, and then some information about liability and depression screening. Medicare does waive the deductible and copay, so there is no patient responsibility for this service. But remember, if Medicare denies your service because too many services within the time period, you do want to consider getting that ABN for your patient or from your patient. Present that to them beforehand. In the event that Medicare would deny it based on frequency, then the patient would be responsible for that service. And here's some resources for you. So that takes care of the depression screening fact sheet, available out on our website. We also have some training available, much of the same information. And then here I've included for you the embedded link to the playlist for depression screening, all of those recordings of past presentations we did, and there were a lot of them. Here is information that speaks to that IVR operating guide. While eligibility is no longer available on our operating guide, there is other claim information, of course, that you can use for help in determining if you can bill for depression screening. This slide does include an embedded link to the guide, which includes the table of contents. And this is an old screenshot that I used here on this particular, sorry about that, on this particular slide. So eligibility is now not part of that operating guide. I need to update that as well. So I need to fix that. Portable user manual. This is that portable user manual we have available on our website. You can link to it in the big blue square near the top of the page. Portal user manual is right here under the login button, or under that login button. You can also scroll to the bottom of any of our web page. There's a big blue box there. There is one section labeled Education Opportunities. You can find a link to the portal user manual there. And remember, this is illustrations and step-by-step instructions on using the various functionalities of our portal user manual. So you can use CSNAP, or not CSNAP, SNAP rather, the Secure Net Access portal to check eligibility or that next eligible date. Okay. Next up is HETS information. This is that HIPAA eligibility transaction system used by electronic billers I mentioned earlier. Here's a link to that web page where you can find next eligible websites. And also, next up, I get back over here, the portal user manual eligibility check. I just wanted to include this slide to remind you that the preventive service category box is just one of multiple choices that you can look under eligibility information and SNAP for. The box will be blue if there's information available, and once selected, the box is going to turn white. So information there. If you're seeking information about Medicare Advantage, here's where you can find that. Remember, WPS can't answer questions about claims or payment for those claims processed by an MA plan. You need to go to the plan for that information. We do have a YouTube video called Medicare Advantage Plan Denials that will be helpful to you if you're looking for that information. And here's where you can find that CMS definition of primary care setting that I mentioned earlier. It is found on a quick reference chart for Medicare preventive services. If you click here on the link that I've embedded in the presentation, you'll be able to find the CMS description of primary care setting. And here is where you can find Medicare secondary claims help, the fact sheet, the questionnaire. I've included a link to the Benefits Coordination and Recovery Center. That's another contractor that actually takes the information and the eligibility information and sends that information over to CMS. So they coordinate with CMS to make certain that those eligibilities and information in the CMS master files are up to date. And we do have a YouTube playlist for Medicare secondary payer you might be interested in. That brings us to questions and answers, and we don't have a lot of time, but let me ask you this, Ashley. Did we receive questions in the chat during my presentation?
Mary, we have not received any questions in the chat.
Well, then it makes my job extra easy today because we don't have to build time in for those questions or run over on time. But just in case you're like me and after today's event you think of a question that you really wanted to have asked me, you'll get a chance to do that, and I'll tell you about that in just a moment. First of all, though, I do want to talk to you a little bit about a survey that we ask you to complete. It's brief. When you disconnect from this webinar today, you're going to be directed to a CMS survey. I am having Ashley place the link in the chat. I really hope that you will take a moment to provide feedback on how I did today. If you're watching this video as an encore, you're going to see a pop-up at the end of the webinar with a picture that says survey. So we ask you to complete the survey. Let us know what you liked, what you didn't like. As you can tell, based on those changes we've made to our education in the past, we've added chapters to our recordings out on YouTube, so you can easily move through a presentation based on kind of what looks like a table of contents. You can jump around. We've also added training indicators to our webinar descriptions, so you know if the information in that webinar is going to be helpful based on what you do. What are your tasks and responsibilities? So as you can see, your opinion really does matter, and it really does make a difference. So please take a moment to complete the survey. After disconnecting today, you're going to receive a thank you for attending this webinar. It's going to contain contact hours, and you can submit that to an accrediting body for continuing education units. But if you joined only by phone, in other words, you can hear me, but you can't see the presentation, you're going to get a different email generated from WebEx, not from WPS. What you'll need to do if you need continuing education units is send a message to our education mailbox. In the subject line, put today's date and the name of this webinar, and ask us to send you a certificate of achievement. If you do that, we will check our attendance records. We will make certain that you are on the list, and we will send you that certificate that you can then forward to an accrediting body and ask them for continuing education units. Now, here is the part about those questions. If you think of any presentation related questions, those can be emailed for up to 7 days following today's event, and I will be certain to either respond directly to you or create a list of questions and answers that I can share with everyone. I know I did get some great questions during the registration process, but I worked into my prepared remarks today the answers to those questions. So if you submitted a pre-submitted question, I should have already covered it. And if I didn't, I apologize. Just let me know if you have that question still, and I will make certain I answer it. This brings us to the end of today's webinar. On behalf of myself and Ashley and all of Provider Outreach and Education, I do want to thank you for being here and taking time out of your busy days and schedules. I do hope that you will join us for future events. You may now disconnect. Thanks everyone. Have a great day.